Hi, everyone. My name is Maria Malana. I will be your host for Global Ground Rounds with Global Offsite Care today. And thank you all for being here today. I'm happy to see many familiar faces and names. This presentation is CME approved. So if you would like to receive CME credits for this presentation, please do so through the link that I will put in the chat box. For today's presentation, please download today's slide as it will be helpful during the live demonstration. And I will put the link in the chat box, so please download that. And this video will be posted to our YouTube channel within a day or two. I will also put the link to our YouTube channel in the chat box. And other than that, I think we are ready to go. We have our Global Offsite Medical Director here, Dr. Pecchia, who will be introducing our lecturer for today, Dr. Brown.
Marielle, thank you so much. Always appreciate your good work and looking forward to today's session. As Medical Director of Global Offsite Care, welcome to our monthly edition of Global Ground Rounds. Before introducing this morning's guest speaker, I'd like to thank those who attended this past weekend's celebration and fundraiser for Global Offsite Care. Sorry about the background noise. But anyway, it was a success and so much fun to be there with everyone, including many of our volunteers and the leadership of Global Offsite Care. So thank you for your support and our past and new supporters as well. So that said, in keeping with our tradition of speakers and topics pertinent to the growth and development of Global Offsite and the mission of telemedicine for the underserved, welcome to this morning's presentation by Dr. Joachim Brown, who will be presenting on common uses and advantages of point-of-care ultrasound in the clinic and hospital. This session will include a didactic lecture followed by a demonstration on the indication, technique, and image recognition of common uses of point-of-care ultrasound. And we'll identify technique and image recognition of key landmarks for cardiovascular, respiratory, renal, and GI systems. Dr. Brown's currently the clinical director of the Office of MedSim, Medical Simulation at the College of Osteopathic Medicine at Pacific at Western University in Pomona, California, from where he graduated in 2004. He currently also works as an attending physician at Arrowhead Regional Medical Center in the Inland Empire of Southern California, and works as a hospitalist taking care of the underserved in that area from the residency, also from which he graduated in 2009. So for the last 10 years or so, his daily mission has been to educate medical students and train family medicine residents to incorporate point-of-care ultrasound into their curriculum and daily patient care. He's provided basically his life philosophy, lives by simple rules. Family comes first, teaching and soccer are tied for second. He tries to grow his own food, but says his tomato production needs some work. Hopefully his chickens start laying more eggs soon. Anyway, welcome, Dr. Brown. So excited and glad to have you here this morning.
Thank you, Dr. Pecchia. Yes, with the prices of eggs, I do hope my chickens get their act together and start laying more eggs. Before we get started, I'm so humbled to be amongst so many familiar faces and probably unfamiliar faces joining in from, it seems, potentially around the world. So very nice to be here. A couple of disclaimers before we get started. Number one, this is the first time we're using this type of technology on our end in the sim lab. So I just want you to remember, if anything goes wrong, it's not my fault. Blame someone else. Okay, we'll find the right person to blame on that one. Number two, we're going to do it a little bit differently. PowerPoint comes first, but it'll be only about 10-15 minutes. I just want to give you a quick overview of what we're going to cover. Ultrasound is a hands-on activity. I want to give you as much hands-on visual as we can. So we're going to then switch over after the PowerPoint to the patient presentation that we have, where we're using ultrasound. So that's that. Number three, I don't have any financial ties to any of the products that we are using during this presentation. You'll see me using certain types of ultrasound probes. So no financial ties there, but I'll be honest with you, maybe I should, because nowadays raising children can be very expensive. Okay, maybe we can cut that out on the recording so they don't hear that part. So those are the disclaimers to start with. Let me share my screen so I can show you the PowerPoint that we're going to very quickly just peruse through. So common uses, what we're going to focus in on is what are the main key things that we can ultrasound that will help you in patient care, both in the clinic and hospital setting. Now, a lecture like this can go on for weeks. I wanted to give you an overview of what I try to teach my residents, both in hospital and clinic setting, of what are the important views to get to first. Okay, so let's move it on over here. Now, here are some objectives that we always have to write, but nobody really reads, and that's okay with me. Something to be said about this cartoon character here. We always are supposed to share something with ourselves before we start these presentations. So here we go. Here's some sharing that I will do. We have a wonderful student here in the university that actually can draw very well. So they thought, hey, why don't we make cartoon characters of our professors and attending physicians? So here it is. Here's mine. Now, I didn't know the uses that we can use on this, but it turns out, just to let you know, my kids listen better to cartoon dad than they do to real dad. So now what I'm doing is I'm pasting this guy onto little notes with a little saying, hey, why don't you get your homework done? Or be nice if you helped out your mom today. And they're doing it. If I were to say it, they don't do it. If I put it in a sort of cartoon character form, they do it. So I'm telling you right now, this may be the way for those of you who are raising children to maybe get them to do more things that are appropriate. Now, I also want to say, I'm going to take this a step further. I'm going to try this on my wife. All right. The next note I'm going to make, it's going to say, you know, my dear, why don't you take out the garbage for the next month? Okay. Let's see how that works. I'll let you know how it works, maybe during the ultrasound part 2 lecture, which will be coming up maybe down the road. But anyway, cartoon dad seems to work really, really well with your kids. Here we go. I got to give you some intro slides in regards to ultrasound, just to kind of get your appetite going here. And here you go. Dusek, back in 1946, this is what the first ultrasound machine looked like, right? We can't really wheel this around the hospital or the clinic setting anymore, but we've come a long way. Notice now what we have, very portable types of ultrasound that we can use at point of care, meaning physicians, medical personnel actually carry these in their pockets and pull them out just like they would their stethoscopes in order to do a quick ultrasound examination on the patient. So we've come a long way, and now it's being used more and more. Other things, they come in all different shapes and sizes, okay? We have the wireless type. We have the common ones that attach to your iPad. We have ones that can actually attach to your fingertip. We have flexible ones that we use for transesophageal ultrasounds. Again, here's another version of a wireless type of portable ultrasound, and even ultrasound small enough to get into the lumen of blood vessels, all right? So those are the array of transducers that are now being produced, and they're giving us much better versions of patient care. Now, when did this all start? Well, it turns out that in the 1960s, cardiology fellows were being trained to do point of care ultrasound already. Then, of course, OB picked it up as well, and they were doing it at the bedside. And then it just kind of escalated to the others. And from 1980s to where we are now, you see all specialties have started introducing point of care ultrasounds in their profession. And it also is now heavily indoctrinated into the medical schools, because when we do graduate these students, we want them to be ready to use ultrasound on the patients, okay? So this is how medical specialties got involved and some years behind it. Now, what can we ultrasound? I mean, any lung and any system, any part of the system, we can ultrasound. Like over here, your main ones right here. This is basically the cardiovascular, respiratory, GI, and GU system. Okay, those are the main systems that we like to ultrasound, and it tells us a lot about the patient's current condition. But other things can be ultrasounded as well. We're ultrasounding eyes. We're ultrasounding, of course, the thyroid gland, lymph nodes, male reproductive systems. Vascular is very important these days as well. So lots of indications when it comes to point of care ultrasounds. Now, this takes us to, let's get past the intro. Your digestive juices are flowing. And let me show you some of the views that I would recommend would be the most important views to learn in regards to looking at the cardiovascular system. So I would tell you that in regards to the cardiovascular system, there are 3 windows I would focus in on first. First would be the window called the inferior vena cava view. And here is how we position the patient. And here is some detailed showings of what it looks like when we do this. We're going to show you this live on the patient in just a second. I just wanted to make sure you have this as a reference. And then we'll go through how we place the probe and where we place the indicator on the actual live example that we're going to use. Additional windows that we will use for the cardiovascular system include what's called the parasternal long axis view. Yes, we use these type of words around the hospital and clinics when we're saying, hey, did you get a good plaques view? Another way to say this is plaques. Notice P-L-A-X, okay, plaques view. Did you get a good plaques view on that patient? I got a good plaques view. Let me see it. Oh, wow, that's a nice plaques view, right? So we use this type of terminology to let people know which view that we got and what is in that view. Again, we're going to go into that in more detail when we're actually using the live demonstration today. But this is a good reference slide to have to make sure you remind yourself how to get to this point. Another one will be the subcostal four-chamber view, also called the subxiphoid view, because we're right beneath the xiphoid process here. And another good view here, because heavily used in ER when patients coming in for trauma, a nice quick way to look at the surrounding of the heart, making sure we got nothing going on from trauma like pericardial fluid accumulation and things of that nature. So a good view to get under your belt as well. And we'll look at that one in specifically. Now, there are more views for cardio, and more views are even coming out to look at things like different places of the aorta and things like that. But for the most part, starting out, and especially for a 1-hour lecture that we have today, those would be the ones I would recommend are the top 3 in regards to cardio. So let's go to renal. What views would be important in the renal point of care? These are fairly simple because what we want to do is take a quick peek at our kidneys, make sure everything is going okay in there. And they're called the long and short axis view of this case. The right kidney will show you how that's done. Here's a nice picture on where that probe goes when you're looking at a long axis or a short axis view of the organ. Or this is the explanation of how the patient should be, where you place the probe and things of that nature. Again, we'll go through that on the live example. We have the same for the left kidney. We want to take a quick glance at the left kidney. Why? You know, kidneys tell us a lot, especially if you focus into these calyces here. And that's what we'll find out. These are the calyces of the kidney. And it turns out the kidneys can tell us when it's under pressure. And when it is under pressure, these calyces actually start to spread apart and urine starts to displace the calyces. And that shows us a different version or different picture of this currently healthy kidney. Again, this is how we place the patient and place the probe on the patient when we're dealing with the left kidney. And then last but not least, we do want to take a look at the bladder. That's another view we want to take a quick look at. You know, lots of nurses are doing this on the floors now just to see if somebody's able to urinate. And they do post-void residuals, as we call them, to make sure patients are actually able to empty their bladders. So a quick and dirty way to look at the bladder and see if the patient's able to void. Now, this is how we place the probe again for the long and the short axis view. Last but not least is pulmonary. And pulmonary is interesting because the ultrasound isn't very good at looking at the lung. The lung is filled with air. Ultrasound doesn't like air, likes to refract all the ultrasound waves in the different directions, giving us very weird artifacts. So we have to know artifacts when it comes to looking at a healthy lung. Now, the most important views for the lung that we're going to go over is going to be what's called an anterior point view of the lung, just to show you what a normal artifact looks like. Believe it or not, a lung, normal lung, actually appears like this picture here. It shows these repetitive horizontal lines that we call A lines that arise from the pleural line. This is actually a normal looking lung. The reason we get this, lots of physics involved. We do not have the time or the energy to go into that, but it does show you that this is one way of looking at a healthy lung. Now, the point that's of most interest to us when it comes to the lung is called the posterior point for the lower lobes. We also call that the PLAPS view, okay? PLAPS stands for a very long word, posterior lateral alveolar pleural syndrome view. And this is one to learn because it turns out when you're looking for the PLAPS view, you're looking at the posterior portions of the lung. And gravity likes to pull things down into the costophrenic angles. And this is a great view to look at those costophrenic angles down in this region here, okay? That's where those costophrenic angles live. So we'll show you how to take a quick peek at those costophrenic angles to see if any fluid has actually accumulated there, such as pleural effusions, or if the lung doesn't give you A lines anymore, like in heart failure, and it gives you different kind of lines. Again, gravity tends to pull things down, and this is where we find most of the pathology when it comes to the lung. And that's why we focus in on this posterior lateral view. This is a point I make with my residents. That's the one they got to learn. And by far, probably the hardest one to get because of the position of the probe. And we'll go through that here in just a moment. So this PowerPoint is for your reference. What I want to do now is I'm going to stop sharing this. We're going to now move to another room, and I'm going to meet you there in the next couple of minutes. Well, we're going to have a patient on the table with us on the hospital bed, and we're going to take out an ultrasound, and we'll be able to show you both where I'm placing the probe and what the ultrasound has to show for us. All right, here we go. You should see two screens now. One screen is going to be where we're going to ultrasound the patient, and the other screen should show you what the ultrasound is showing. So having said that, the first thing we want to do is actually remind ourselves of these points that we just learned about. So we're going to ask our patient just to put hands on the side. We're going to open up the drape here and remind ourselves when it comes to the cardio, respiratory, and renal system, which gives us a good idea about what's going on with the patient, what areas are we interested in? So let's see if we can draw on this patient first to show you where we want to be. The first structure that we want to actually start to investigate is called the inferior vena cava. Now, the inferior vena cava is going to run just right to midline. I find where the costal margin is. It likes to run under the costal margin. So inferior vena cava, it's going to come down like this. And that's what it looks like. Now, it comes all the way up to the top here, and it'll connect into the right atrium, okay? So that's going to be the next part. Right atrium is going to be here. And then we can draw the rest of the heart on this section there. So what we're interested in is we want to take a peek at the inferior vena cava, because that seems to be still one of the best places to figure out the patient's volume status based on it being collapsible or not collapsible, okay? So important structure. Then we'll come up here to the heart, and we'll do the Plaque's view to look through the left ventricle, okay? Plaque's view is going to be about right here. And it's going to show us the left ventricle and the left atria with a little bit of the right ventricle as well. So IVC view, then we have Plaque's view, and then we even have a subxiphoid view, which is here in the xiphoid area, looking up, trying to look up at the heart. We'll capture a little bit of the liver as well, and I'll show you that when we see it. Those are the 3 points on the cardiac exam that I want to look at first. So why don't we start with that? Now, some individuals don't have very good cardiac windows based on how they're built. So we'll see. I haven't seen this patient yet before, so I'm hoping we chose a good one, okay? Not your fault. It's not your fault. Okay, so here we go. When we do the IVC view, so here we go. The best preset for the IVC view is actually the abdominal preset. So I'm going to go on the abdominal preset here, press select. And now with the indicator, every probe has an indicator. Indicator usually is a mark on the probe that allows you to have the same orientation with every picture that you do. The indicator here is marked in a blue dot. My indicator needs to go towards the head, and I want to basically go straight on this IVC in this fashion right there. So we're going to go right over here and increase that gain a little bit, and let's see what we have here. So on your screen, go ahead and show my probe first. Okay. Notice on the probe, this is the technique. Your indicator is going to the head. You're holding the probe like this. Your hands should be on the patient in a way so you can stabilize yourself. If you're right-handed, you're standing on the right side of the patient. And now you must rock your way under the costal margin to find the IVC. And if you look at the screen, you see some structures. Now let's see if we can, I don't have a pointer on the screen, but we're going to film the screen, and we're going to see if you can follow me along with a pointer that I can use here. Notice the structures that we need. Number one, we have the liver. So we have the liver in view. We have a long tube right beneath the liver, draining it, and that is our IVC. The reason I know that's my IVC, it's because I see my heart, and I see the IVC going straight into my right atrium, just like how we drew it on the patient. Now, this IVC is nicely distended in a good way. Let's see if it also collapses, meaning when the patient takes a quick breath in, do you see it actually squeezing together? So we'll ask the patient to take a quick breath in, such as, and then one more time. Notice that when there is respiration or inhalation, the patient is able to compress the actual IVC. That tells us that the patient is, number one, hydrated, but not overhydrated in a way where he can't collapse the IVC by taking a breath in. Now, what does that mean when it comes to your patients? Well, let's put this in perspective.
If my patient was a heart failure patient and I see that his IVC is pretty enlarged, but it is able to actually reduce in size when actually taking an inhalation, that's a good sign. If he was a heart failure patient and he can't collapse the IVC, I would argue that maybe we need to increase the Lasix in order to diurese this patient more, since all this blood flow is going into the heart and it may not be able to keep up based on the heart failure that he has. Now let's go the other direction. What if we had a sepsis patient? A sepsis patient, you want to see a very distended IVC because we want as much fluid in these patients as possible. If we see that the IVC is almost non-existent or very collapsible in inspiration, you could argue that the patient requires more fluids in regards to the sepsis and actually hang a bag of normal saline or lactated ringers to give him the support he needs to prevent any septic shock. So that is how we get a better idea of the patient's hydration status using the IVC. Now, let's go back on the patient's body here and remind ourselves we've done the IVC view. Let's go over here, since we're in the neighborhood, and look at the actual subxiphoid. I'm going to put my gel right in that subxiphoid area. This isn't the best probe to use because it has a very big footprint. We need a little bit more gel to make sure we have good contact here. Notice how my hold changes. All of a sudden, I'm not holding it like a pen anymore. I'm actually holding it above. Indicator now is going to go more to the left hip. And my index finger is there to depress down, almost making it like a shovel, so I can dig down underneath that xiphoid process, because I have to look quite a distance up to see the heart. So here we go. We're going to put all this at the subxiphoid area. We're going to press down, and we're going to try to find the heart. Now, it turns out, with the subxiphoid view, sometimes it's easier when we tell the patient to take a deep breath in because it brings the heart down. Diaphragm makes more room. So we'll have the patient take a deep breath in and hold. And let's see if we can find what we need on the screen. Now, one thing that we have to remember here is once we move away from the IVC, we have to change to the cardiac preset. Okay, presets are very important to keep the structures very similar. We'll tell the patient to breathe for a second. He was doing very well there, but once the patient turns blue, that's an indication to remind him, go ahead and take a breath in. So let's see if we can get a better view here. One more time with the breath in and hold. And we can start to see a structure similar to the heart. He doesn't have the easiest IVC view, and this probe isn't ideal, but you can start to see that left ventricle is here, and the right ventricle is on the opposite side. The septum is coming into view right in here, and you can see the contraction of the heart very nicely on the screen. The liver is on top, as we reminded ourselves that we have to go through the liver to see the heart. And now we're starting to see a better organization of a 4-chamber view of the heart. Now, make sure the patient breathes. Now, what does this tell us? Well, since the liver is right next to the right ventricle here, I can see if there's any fluid inside that area, in this pericardial sac. And if the liver butts up right up against the actual right ventricle, I could say, well, at least I don't have any pericardial fluid in that region there. And I can also look around the heart to see if there's any pericardial fluid. I also like to see how the left ventricle contracts and how big the right ventricle is. Because just in general, right ventricle should be a third less than the left ventricle. Anything different than that means there might be something going on with right ventricular pressures, lung issues, or maybe too much fluid in the person's body. All right, let's go to the last view in regards to cardiac. And we're going to call that the plaques view. We'll get back on our patient's chest wall here. Remind ourselves that the peristernal long axis view of the chest would be right here, just in between the third and fourth intercostal space. So we're going to put our gel right on that X right there. And we're going to remind ourselves where the indicator goes. In the plaques view, the indicator has to point to the patient's right shoulder. We're going to hold the probe like a pen, and we're going to try to balance ourselves on the patient's chest wall. And down we go. Now, in order to kind of find the right spot, we tend to move around a little bit on the chest to see where can we find the best place we can go through the ribs? And it seems like this is a good spot right here. So here is the plaques view of our patient here. Let's look at some of the things we're able to tell here. We're starting to see an outline of the left ventricle, because that's what the plaques view focuses in on, the left ventricle. Now, the left ventricle is cut here, but we could extrapolate an imaginary line going out like this, telling us that that's where the left ventricle would be. The most active valve that you'll see in the left ventricle is going to be the mitral valve, and you see it there. Opening and closing. Attached to it is the chordae tendineae, and down below attached are the papillary muscles. So we can see a pretty good version of that here. And now notice the relationship between the septum, which is here, and the actual mitral valve, which is there. Notice that the septum almost touches the mitral valve when it opens. That's actually significant because it tells us there's most likely good cardiac function occurring here, meaning ejection fraction is most likely normal and there is no dilation of a heart. If this distance between the ventricle, the septum, and the actual mitral valve is less than 1 centimeter, we could say that the ejection fraction most likely is normal. Another thing to look at is as we move back a little bit on this heart, let's see if we get a good view of this. Well, not the best view here. And usually we see if the patient can lie left lateral side to see if we get a better view. Let me do that for a second. Let's have the patient lie on the left side, raising that left arm. Let me show you how that's done. If you don't see the heart very well in these plaques views, tell the patient to go ahead and raise their left arm above their head and roll over and lie on their left side. This brings the heart closer to the chest wall. Now, do the same thing though. Stay on the plaques view, and let's see if we can bring that heart closer to the chest wall. And notice just with moving the patient left lateral, we can start to see a better structure on the heart. Same thing. You have the ventricle. Septum is here in the middle. We note that the mitral valve has a nice relationship with the septum. They're basically almost touching each other. So all of that looks very, very good. I see good contractility throughout the ventricle there. I see the right ventricle up here, smaller than the left ventricle. To me, that's a good sign. And for right now, this would be a good initial finding on the patient's plaques view. So let's leave it at that. We'll tell the patient to come on back to lying on their back. So given time constraints, those are 3 views I make sure my residents know well in order to do this at the bedside. Let's move on to the renal part of this all. Most of the time when patients are coming in, you'll see elevations in their creatinine. And right away, you're thinking, man, I have to rule out some renal possibilities there. One of which is post-renal obstruction. Creatinine can be increased with post-renal obstruction, which means enlarged prostate. Our patient's not old enough yet for that, or neurogenic bladder, things of that nature. So it'll be a quick way to look at it. What I like to do is look at both kidneys in the long axis view to make sure there is nothing called hydronephrosis. Hydronephrosis is a way for your kidneys to tell you there's increased pressure inside the kidneys. Now, let's do a little drawing because our patient hasn't been tattooed enough, and we're going to actually draw what we need on this side over here. Let's see if Carla can come over here and we can draw this. What we're looking for is going to be the kidneys. And it turns out to look at the kidneys, the best place to go is in this sort of axillary line area here. The right side, the mid-axillary line, marks the spot for the kidney location. So mid-axillary line, draw a line down this way, about 9th, 10th rib interspace, so about right here. Your kidneys lying deep in the tissue would probably look like, and let me remind myself, they are leaning back. So kind of like this. Now, I am not Netter by any means, and I've forgotten most of my anatomy, just don't tell any of me my anatomy professors. But this is where the kidneys lie. And it turns out that the liver, of course, is very near and close to the kidneys. So when you're seeing kidneys, you're going to be also seeing part of the liver. So let's check to see if we can find this space here where we can actually see a cross section of the liver and the kidney together in a long axis view. How do we do that? Number one, we have to make sure we have enough gel on our probe. Number two, we're going to go long axis view, which means the indicator needs to go to the patient's head. As said before, we're going to go mid-axillary line, about 9th, 10th rib interspace. Let's see if we get lucky. Notice the hold. The hold changes again, but you always want to make sure you have some control. You're touching something else besides the probe, so you can stabilize the probe on the patient. So as we place the probe here, we get to the liver. So now we're starting to see liver on the screen, but also we're starting to see the kidney on the screen. So let's fine tune this a bit for you so we can get a good visual on this. Now, we're still in cardiac view. It's important when you're doing these structures to go back to the view which is best. And in this case, it'll be the abdominal view. In these all-in-one probes, it's important to always toggle between the best sort of views, and abdominal view is the best when it comes to there. Now, I'm going to increase the gain a little bit. Notice what gain does. Increases kind of sometimes how visible things are. That is that the liver, so his kidneys lie a little bit more inferior. I'm going to come down here. And what we're starting to see now here is some ribs, which are not nice. And we're trying to fight the ribs. But let me show you what we have on the screen for you now. Just as we thought, we have the kidney right here. You can see kind of a jelly bean cut in the long or long axis right there. Notice the inside of the kidney is bright and white. Okay, we call this hyperechoic. To me, his calyces are nicely packed together, and there is no urine causing pressure, pushing them apart. There is a rib that's causing us some issues in regards to seeing things, but there is the liver edge right there. You can see the liver edge there. Liver edge, kidney, calyces, no hydronephrosis seen here. So I don't think this kidney is being obstructed. And then the very famous Morrison's pouch, which is this fascia that lies between the liver and the kidney, which is some place we look for fluid, especially in trauma patients coming in. Fluid would collect there first and would make this triangle, which is very bright and white, which is normal, dark, which would be abnormal. This is the same view we would do for the other side of the kidney, but in the other side, we would see the spleen. If we want more of that, we can go through that at another time. I would like to also go to the bladder, because let's say that kidney on the opposite side looked good as well. Your last stop would be just taking a quick peek at the bladder. Now, we've been trained to palpate bladders. We've been trained to palpate bladders if they're distended. But I would say in some patients, it's harder to palpate a full bladder than in others. So it's important also to have a technique to see if somebody has, urine or is holding urine in their bladder. Now, what we want to do is go below the belly button at the belt line. That's usually the sweet spot. You don't want to go on the pubic symphysis because the ultrasound can't see through the bone. So you can do long axis view first. Indicator again goes towards the head. You place it right at the pant line. Now it's important that you really rotate that probe into the pelvis to make sure you can actually find the bladder, because the bladder lies very, very deep in the pelvis in some patients. Now, right away, I'd be asking the patient, before you do this exam, when did you last go to the restroom? Was it right before the show? Notice the patient went to the restroom right before the show. Evidently, he didn't get the email to not go to the bathroom. I'm going to check the short axis view. There ain't much there. Okay, a bladder would show as a very dark hypoechoic structure. And all we're really seeing is some bowel moving in there. You can see some peristalsis going on in there where the bladder is supposed to be. So bladder completely empty in this view. And that's a good sign. Patient is voiding appropriately. So the increased creatinine isn't coming because of post-renal obstruction. The increased creatinine could be coming from pre-renal or intrinsic states, which is now where our differential goes. But at least we can wipe this one off the list. Let's go to our last one because we're coming down to the end here. And I do want to take some questions here at the end. Let's go to our lungs next. Probably the most confusing part because we're dealing with artifacts. Let's do some drawing first on some of the places I'm going to show you. So let's start up on top here. Let's make sure we have our pen. We're going to do the anterior view, which is going to be up here on the chest. The anterior view allows you to look at the upper lobes of the lung. So what we're going to do is we're going to find two ribs. If this is one rib and this is the other rib, we want our probe to go right in between those ribs to look through that intercostal space. Okay, so that's where we're going to put and place our probe for this anterior view. The other view that we want to do is the most difficult one. That is called that posterior lateral view. Okay, and I'm going to come around to the other side to show you what we're dealing with over there. Now, on the posterior lateral view, what we want to be able to do is expose, and we're going to have the patient come out of that gown if you can. Slip that out. That's perfect. We need to expose the posterior axillary line and beyond because the costophrenic angle lives down here. So this is usually a two-member approach where we take the arm of the patient and very gently rotate it over. Now that exposes this posterior line and beyond. This is a great way to get a look at the costophrenic angle. Remember, costophrenic angle is a good recess for anything that can sort of settle into the lungs, especially like fluid. So what we're looking for is we have to find the diaphragm. Okay, the diaphragm is going to help guide us. On ultrasound, the diaphragm is a very hyperechoic structure. Notice we're starting to use terms that we use in ultrasound. We don't say bright. We say hyperechoic. Why? It makes us sound better, you know? So hyperechoic structure here is the diaphragm. Living right beneath it and hugging the diaphragm is going to be the spleen. Okay, you'll see an organ that lives right beneath it. And that'll be the spleen. You'll see a cross section of the spleen. So moving towards the feet from the diaphragm, you'll see spleen. Okay, we'll put an S. Moving, of course, up on top of the diaphragm, we're going to see lung. And we're going to see that costophrenic angle, which sits back here. This is the costophrenic angle that likes to fill up with fluid on your heart failure patients, even on your pneumonia patients that have effusions. Okay, so that's an angle that we're really interested in. So let's take a look what that looks like when we're actually putting an ultrasound on that area. So we're going to ultrasound that posterior lateral point on the left. Let's see if we can find those organs that we talked about. Here we go. So we're going to do that side over there. So I'm going to keep that arm in this fashion there. I'm going to reach around. My knuckles go on the table. And I'm going to start in this region right here to see what we're getting. Now, on the screen here, you're going to see some A lines. That means I am in the lung tissue. Let me show you what that looks like. This is all healthy lung. These horizontal lines that you see moving down into the lung space means my alveoli are filled with air. Fantastic. That is what I want to see. Let's move towards the feet just by one rib. Let's see if we get closer to the organs that we talked about. We're starting to see something different here. If you look very close, I'm going to zoom in here. Up on top here, we have something that looks more like an organ. This is your spleen. So now we found the spleen. Spleen and lung. It'd be nice to find the diaphragm. Notice when the patient takes a deep breath in, it's all lung. Now they take a deep breath out. Diaphragm moves up and say hello to your spleen. Again, deep breath in. All we see is lung. Deep breath out. or breathe out. And now we see the spleen again. So it's up to us now to see if we can find the diaphragm. And notice right here, we're starting to see the diaphragm. I'm going to stop this here for a second. This hyperechoic line is your diaphragm. And I know it's early, so come along with me if you dare. Below the diaphragm, we know we have spleen. That's an organ. Notice what I have here in the costophrenic angle. You could argue that this tissue here in the costophrenic angle looks very similar to the tissue that I see here with the spleen. So now you're asking, does your patient have a spleen in the lung area? I hope not, or else we'd be sending you to the ER, okay? But what we have here is a normal finding called a mirror image artifact, where we know the ultrasound doesn't do a good job ultrasounding the lung. And it turns out when you're close to the diaphragm, things get reflected. And what you have being reflected here is the spleen into the lung space. And that is called a mirror image artifact, and that is normal. We don't have a fluid collection, or else this costophrenic angle here would be hypoechoic or dark, and we don't see that here. So at least we can say on our exam, in our objective findings, based on POCUS, using the PLAPS view, no pleural effusion noted, okay, and A lines noted. So at least we can say that much. I'm gonna undo that here. And again, this is a very, this is a great view of the spleen and the kidney together now too. We have kidney down here, spleen there, and the diaphragm here. Now, if I start moving up, all we see is lung. And that's what I want to see. I don't want to see anything else in that pleural space. And that is your PLAPS view. All right. So just to review, and we did this very quickly, in training right now, at least for the residents that we have on the family medicine service doing hospital medicine, when we have somebody coming in with shortness of breath or anything else, chest pain, shortness of breath related abnormal labs, this is part of their physical exam. And we want to make sure that heart, kidneys, and lung aren't storing something that might be a clue to what's going on in their body. We have the opportunity now to look through the body, in addition to using our stethoscopes, in addition to using our palpation skills, which we don't want to forget to do. But this gives us an added feature to make sure we try to figure out what is going on with the patient before we start unloading with CT scans, MRIs, and things of that nature. This might refine on how we would work up the patient. What I'll do next is I'm going to go to the desk and I can field any questions, or why don't we do it this way? I think we can hear audio here. Mm-hmm. Let me open up the room for any questions that you may have in regards to what's going on. You know, it's a lot to take in.
Dr. Brown?
Yes.
I've been wondering why, when you're looking at the PLAPS view, the costophrenic recess looks like it appears deep to the spleen. Is that correct? And I'm wondering why. That's confusing to me anatomically.
It's confusing to me as well. I would tell you the costophrenic angle as it goes behind the body goes very, very deep. And it doesn't just stop at the side. It goes all the way into the back. So costophrenic angle is a potential space that is very, very broad and flows very, very deep. And sometimes it looks like, because the diaphragm dips down as well, it looks like it is deeper than the spleen. Does that help a little bit?
Yeah, that makes sense.
Yeah, it's early. Don't get too complicated now, okay? Not too much, enough coffee, I think. But yeah, that's how you want to look at it. Good question. Anyone else? And I know this was a lot of information in a very short period of time. If there is potential for people wanting a more specific system that we want to just dissect, we can certainly, I'm sure, set up times in the future to make that happen as well. But this is kind of a good overview of some of the things we're able to do now in regards to point of care ultrasound. So we'll open it up one more time.
Dr. Brown,
Yes.
I have a question for you that's not exactly clinically related right off like you were talking about, but I'm been involved for a long time in teaching osteopathic principles and manipulation, and I'm been wondering for a long time about the potential for the use of ultrasound like this as a teaching aid in things like structural diagnosis and manipulative techniques. It seems to me there's things we could measure, for example, pre and post treatments on the diaphragm or the carpal tunnel, or can you put an ultrasound head on a vertebra and have a student palpate it and get some idea about posterior transverse processes versus symmetry or sacral sulcus depth, things like that, that we could use as teaching aids and kind of research in helping people to learn palpatory skills and get more objective measurements.
Dr. Ruby, first, I'm honored that you're even here. You're an instructor of mine back in my days, so I am humbled. Number one.
I was hired to do a secret report on you this morning. No.
Number two, I think you and I, we need to sit down at a place and drink some water and discuss how this can be done. But absolutely, you are correct. Things can be pubic rami, ASISs, vertebrae. This is how we do lumbar punctures now in difficult patients. We actually measure out the distance over our vertebral body. So absolutely, there are so many things I think that can be integrated into our current OMT to see if we are palpating what we're palpating, and it actually making a difference in the treatment that we do. So absolutely, we need to sit down and talk. I
will get in touch with you, and we for the sake of the audience, Dr. Brown and I work about 100 yards apart, and it's just ridiculous that we never get to talk about these things very well. So I will definitely be in touch with you, and I'll bring something to add to the water if we're going to drink water. Okay.
We'll edit that out.
Thank you.
Thank you.
I just wanted to add one thing on a medical mission that I went on using handheld ultrasound interface with an iPad. It worked wonderfully for that sort of use. It's wonderful you're teaching the residents, but it's also great for medical missions.
Excellent. Thank you, Dr. Ross, for letting us know. Absolutely. Rural areas, no access to CT scans or chest x-rays. This is a good way to look deeper down to see what's going on. Wonderful. Anyone else? We're running at 2 minutes here. I think
I don't know if you have time for this question, but I'm really interested in how a private practice or family medical practice is able to implement this. You mentioned that you do lung ultrasounds routinely on respiratory physical exams, and just like how is that integrated, I guess? And then also, are you able to bill for it? I know people are worried about paying for these machines and making sure the time is worth it as well. Like, yeah, are you able to make it worth it in all aspects like that?
Good question. Yes, a point of care ultrasound is billable. I know certain aspects of it in, let's say, OB and ER and things of that, they are already billing for these. I know for clinic and hospital settings, there are ways to do that as well. You just have to work with billing team and things of that nature. Right now, we're only using it for academic purposes on our family medicine service, but absolutely these are billable, especially if you're doing a procedure that requires ultrasound guidance. Because nowadays, we're using ultrasound to do most of our procedures, thoracentesis, paracentesis, even lumbar punctures we can use. So there we bill it because we can say that we used ultrasound in the process. And there is, I guess, a better return for that since you have to invest in these machines, absolutely. Other things being, in a clinic setting, there's a lot of things we haven't even touched yet in regards to, looking at the knee joint for an arthrocentesis. looking at the GI for potential gallstones. There's all kinds of things we can still, do in a clinic setting as well, that we haven't had even time to encroach at this point in time. But yes, the answer is yes and yes, I think. And I think it's definitely something more to explore moving forward. But I do think I do have to cut this at 9 o'clock. Are we at the point where everything starts to shut down?
Yeah, we can continue until the question and answers is finished. And I do have a question from Dr. Pecchia.
Absolutely.
Yes, so his question is, how is the use of this technology at the bedside typically paid for? Like, who buys it? And how is this bedside use funded during the course of inpatient and outpatient care?
Right. So again, about billing and funding, usually the hospital, if it's a hospital service and not an independent contractor coming into the hospital, would pay for the ultrasound machine. If it's an independent contractor coming in as an internal medicine team, that team would purchase, let's say, the ultrasound. Then, since they have their own billing, the independent contractor would send their findings, their notes to their billing team to see if they can get reimbursed. The hospital, it'll be, hospital would do the same if they're the ones that have employed this, let's say, interventional radiologist or internal medicine doc, and they will be the ones that would be purchasing, let's say, this equipment. So hopefully that sheds a little light on that issue. I may have missed some of the components.
Thank you.
Good, absolutely.
Well, thank you, Dr. Brown, for the insightful presentation. So we are coming towards the end of our time here. As a last reminder, please use the link provided to receive your CME credits. Our next presentation will be on April 12th, and we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again. Thank you so much.